Heart sounds or cardiac murmurs. To better understand heart murmurs, we need to know what happens during the cardiac cycle. The cardiac cycle has two phases. One is the systolic phase and the other is the diastolic phase. In the systolic phase, the ventricles contract. When the ventricles contract, the pressure inside the ventricles rises. As the pressure in the ventricles increases, the mitral valve closes. The closure of the mitral valve leads to the creation of the first heart sound, or S1. When blood exits through the aortic valve at the end of systole, the closure of the aortic valve leads to the creation of the second heart sound, or S2. The closure of the mitral valve is responsible for S1, and the closure of the aortic and pulmonary valves is responsible for S2. After S2, S1 occurs again. The interval between S1 and S2 is called the systolic interval, and the interval between S2 and the next S1 is called the diastolic interval. Now, let's discuss heart sounds in more detail. At the beginning of systole, when the ventricles start to contract, the pressure is very low, between 0 and 10 millimeters of mercury. As the ventricles contract, the pressure in the ventricles increases. This increase in pressure causes the mitral and tricuspid valves to close because the pressure in the left and right atria is about 5 millimeters of mercury. Therefore, when the pressure in the left ventricle rises above that in the left atrium at the start of systole, the mitral valve closes, and similarly, the tricuspid valve closes. The pressure continues to rise until it exceeds the pressure in the aorta, at which point the aortic valve opens. So, there is a time interval from when the mitral valve closes to when the pressure rises enough for the aortic valve to open. This is called isovolumetric contraction. The first heart sound, S1, has two main components, M1 and T1. Under physiological conditions, the opening of the valves does not produce a sound. Therefore, the opening of the aortic and pulmonary valves does not create any sound. Thus, the S1 sound is due to the closure of the mitral and tricuspid valves, not the opening of the valves. In a normal individual, the opening of the valves does not produce any sound. However, in pathological conditions, when there is a problem, the opening of the aortic and pulmonary valves can also produce a sound. Since this happens at the beginning of systole, it is called an ejection sound. After the systolic phase ends, when the pressure in the left ventricle drops below the pressure in the aorta, the aortic and pulmonary valves close, and their closure produces the second heart sound, S2. Therefore, the systolic phase begins with the opening of the aortic valve. Blood is ejected from the left ventricle, and when the aortic valve closes, the systolic phase ends. When the aortic valve closes, the diastolic phase begins. The pressure in the left ventricle drops rapidly, and as a result, when the pressure in the atria exceeds that in the ventricles, the mitral and tricuspid valves open, allowing blood to flow from the atria into the ventricles. In a normal person, the opening of the tricuspid and mitral valves does not produce any sound. However, in cases where the valves are abnormal, such as in mitral stenosis, the opening of the mitral valve produces a sound called an opening snap, which occurs shortly after S2. After the mitral and tricuspid valves open, blood flows from the atria into the ventricles. In most people, this inflow does not produce a sound, but any condition that increases the volume of blood entering the ventricles from the atria or the presence of ventricular dysfunction can cause an additional sound. The sound produced by the inflow of blood from the atria to the ventricles is called S3. S3 can be heard in some physiological conditions, such as after exercise in pregnant women, children, and young adults. At the end of diastole, the remaining blood in the atria is pushed into the ventricles by atrial contraction. In normal individuals, this does not produce a sound, but in pathological conditions, such as in patients with ischemic heart disease or those with left ventricular hypertrophy, LVH, the inflow of blood from the atria to the ventricles during atrial contraction produces a sound called S4. Therefore, blood enters the ventricles during diastole in two phases. First, immediately after the mitral and tricuspid valves open, due to the accumulation of a large volume of blood, about 70 to 75% of the diastolic ventricular filling occurs at this stage, and the sound associated with this is S3. The remaining 20 to 25% of blood enters the ventricles at the end of diastole due to atrial contraction, and in pathological conditions, this produces the S4 sound. There are also some additional heart sounds that can be heard. In systole, there is a sound called a non-ejection click, which is heard in patients with mitral valve prolapse (MVP). When the left ventricle contracts, the mitral valve, due to its prolapsing nature, bulges toward the left atrium, producing a sound that is heard in mid or late systole called a non-ejection click. In diastole, other sounds can be heard, such as in patients with left atrial tumors like myxoma. When the mitral valve opens, the tumor mass moves from the left atrium toward the mitral valve, producing a sound called a tumor plop. Another sound is the pericardial knock, which is heard in patients with constrictive pericarditis. When blood flows from the atria into the ventricles expand and their walls hit the pericardium, producing a knocking sound, which is pathological and not physiological. The first heart sound, S1, is due to the closure of the tricuspid and mitral valves and marks the start of systole. After that, we have the ejection sound, which is only heard in patients with bicuspid aortic or pulmonary valves. The next sound is the non-ejection click, heard in mid or late systole due to MVP or mitral valve prolapse. The next systolic sound is S2, caused by the closure of the aortic and pulmonary valves, which has two components, A2 and P2. After S2, diastole begins. In diastole, the first pathological sound is the opening snap, heard in patients with mitral stenosis. After that, S3 is heard, which is due to the inflow of blood from the atria to the ventricles. Then we have the pericardial knock, due to the ventricular wall hitting the pericardium in constrictive pericarditis. The tumor plop is heard at the same time as S3 due to the movement of a tumor mass from the atrium, especially the left atrium, toward the mitral valve. At the end of diastole, S4 is heard due to atrial contraction pushing blood into the ventricle. After that, S1 is heard again. Therefore, all the physiological and pathological heart sounds are these 10 sounds. Now, a few points about heart sounds. To distinguish S1 from S2, we should place the stethoscope on the patient's chest and simultaneously palpate the carotid pulse with the other hand. The sound that coincides with the start of the carotid pulse is S1, and the sound that coincides with the end of the carotid pulse is S2. Another point is that the first heart sound S1, due to the closure of the mitral and tricuspid valves, is best heard at the apex and is a louder sound, whereas S2 is best heard at the base of the heart in the second intercostal space and is louder than S1. Another point is that S1 has two components, T1 and M1. M1 is due to the closure of the mitral valve, and T1 is due to the closure of the tricuspid valve. M1 is the louder component compared to T1. This means that the M1 component, which represents the closure of the mitral valve, is heard more strongly and distinctly at the apex of the heart, which is typically located in the fifth intercostal space at the midclavicular line. In contrast, the T1 component, corresponding to the closure of the tricuspid valve, is best heard at the lower left sternal border and also in the epigastric area. The M1 sound is generally perceived as louder and more prominent than T1 because the mitral valve closes with greater force and higher pressure compared to the tricuspid valve. Therefore, M1 is heard more prominently than T1. While M1 can be heard throughout a wider area of the chest, T1 is more localized and is primarily heard only in the lower left sternal border and the epigastric regions. Moving on, the S2 heart sound also comprises two distinct components, A2 and P2. A2, which signifies the closure of the aortic valve, is typically louder than P2 because the aortic valve closes under significantly higher systemic pressure. Consequently, we can hear A2 throughout a broader area of the chest. However, P2, representing the closure of the pulmonary valve, is only heard in its specific and localized area, which is the second left intercostal space adjacent to the sternum. If P2 is heard outside its usual and expected area, or if its intensity is increased, it may indicate a pathological condition such as pulmonary hypertension. Let's take a moment to review the fundamental heart sounds we've discussed so far. The normal and physiological clinical heart sounds are S1 and S2, which are often described rhythmically as la-da, la-da, la-da. In this common mnemonic, S1 is represented by la and S2 by da. Alternatively, we can refer to them numerically as 1, 2, 1, 2. In certain physiological or pathological situations, sometimes S2 is audibly split into its two components, A2 and P2. In such cases, the first sound, S1, remains single, but the second sound, S2, is perceived as double. This can be described rhythmically as la-da-da, or numerically as 1-2-2, 1-2-2. The third heart sound, S3, is an abnormal sound in adults and is heard after S2, creating a rhythm like S1, S2, S3. This can be mimicked by the rhythmic phrase la-da-la-da-la-da, or numerically as 1-2, 1-2, 1-2. The fourth heart sound, S4, is also typically an abnormal finding in adults and is heard before S1, establishing a sequence of S4, S1, S2. This rhythm can be described as talada, talada, or numerically as 2-1-2, 2-1-2. In clinical scenarios where a patient exhibits both S3 and S4, we can hear all four heart sounds occurring together in rapid succession. This distinct rhythm is medically termed a quadruple gallop. This complex sound pattern can be described phonetically as lub-dub-ta-ta, lub-dub-ta-ta, or numerically as 1-2-ta-ta, 1-2-ta-ta. Furthermore, in patients who present with both S3 and S4, if tachycardia, meaning an abnormally rapid heart rate, is also present, S3 and S4 can fuse together. This fusion occurs because the diastolic phase of the cardiac cycle is significantly shortened due to the increased heart rate, resulting in a single, louder, and more intense sound known as a summation gallop. This can be heard rhythmically as 1-2-ta, 1-2-ta, or phonetically as lub-dub-ta, lub-dub-ta. In patients experiencing a summation gallop, the shortened diastole causes S3 and S4 to merge into one, producing a distinct, louder, and often pathological sound. Now to provide a concise summary of the heart sounds we've covered. First, we have S1, followed by S2, then S3, and finally S4, which is uniquely heard before S1. In some specific cases, both S3 and S4 are heard together, creating what is known as a quadruple rhythm. Moreover, in the presence of tachycardia, these two sounds, S3 and S4, can fuse into a summation gallop. These represent the main and most important patterns of heart sounds you may encounter during a cardiac examination.